Welcome to folks as you're joining today's session of Arizona Community Grand Rounds. We will begin in just a moment or so as we give people a chance to connect to the session today at noon on Friday, or I thought it was Friday, ahead of myself, Thursday, December 16th, as the date shows on the slide, if you can see it as you're coming into the session. Really fortunate to have a panel conversation today and welcome folks who are participating if for your first time or for your 20th. I think we've had about 20 of these Arizona Community Grand Rounds so far. Today is going to be a very lively and timely conversation on COVID and closing the year on COVID, and we will begin in just a moment. Well, welcome everyone. We will kick off today's session of the Arizona Community Grand Rounds. My name is Mark Carroll. I'm the Chief Medical Officer with Health Choice, Blue Cross Blue Shield of Arizona. Health Choice and the NARB Institute are pleased to co-host these rounds. We're even more thrilled to be able to engage conversation with experts from Arizona and around the country on key, important, and timely topics. Today's title for our presentation is Closing the Year on COVID, a panel conversation. While we'd like to close the decade and if not the century on COVID, unfortunately, COVID's not collaborating with us on that. We're at least going to close the year. Moving into next year, we have an excellent panel conversation today. Before I introduce the panelists, just a reminder, if you can go to the next slide, Jen, that we do these sessions monthly. And the session for January of 2022, on January the 6th, which is a Thursday, is entitled Collaborative Telehealth Care on the Navajo Nation, Increasing Access to Autism Services, with presenters from the Children's Hospital of Philadelphia and the Tuba City Regional Healthcare Corporation. As always in the Community Grand Rounds, the sessions are recorded and will be posted within a few days to the NARB Institute website. We'll put a link in the chat as we go forward so you have access to that, and anyone is welcome to view them. If you have questions, please, during today's session, please feel free to enter them into the chat or the Q&A, and we'll get to them as we're able to. So as we begin today, you've seen in the announcement, we have 4 phenomenal people, physician researchers, and just leaders in our state. Doctors Dave Engelthaler, Rebecca Sunenshine, Bob Orenstein, Robert Orenstein, and Keith Frey, who have become friends and colleagues of mine during the pandemic. One of the great benefits of the pandemic has been meeting and getting to know new people and developing new relationships in the state. We are so fortunate to have these 4 leaders, not just part of our panel today, but with us and helping our work in the state. I'm not going to go into an extensive background on their biographies, which is impressive for each of them individually, because you'll want to hear directly from them. So with that, and a note of acknowledgement and thanks to Mary Jo Gregory, President and CEO of the NARB Institute. Thanks, Mary Jo, and a nod always to our excellent technical assistants coming for these sessions from Jennifer Pierce. Thanks, Jennifer. I'm going to turn the dais, our virtual platform, over to Dr. Dave Engelthaler from TGen to do a first overview. Dave, over to you.
Great, thanks, Mark, and thank you, Mary Jo, and thanks to NARB Institute and Blue Cross for hosting this. I'm really glad to be here. I'm glad to be the opening act for this esteemed panel. You guys get to hear from some pretty amazing folks. I get to start off by talking about something I love, and I know Mark will yell at me if something goes wrong with the slides, so I'm just going to plow forward. I'm with the Translational Genomics Research Institute and formerly with the Arizona Department of Health Services and CDC, and so I have a very strong public health bent, and what we've been doing with using our genomics to support the COVID response. I'll talk a little bit about that and lay some groundwork, hopefully for some further discussion. We'll probably hit on Omicron as well too. So I'm just going to jump into it and then happy to answer questions later on. So just thinking about genomics and COVID-19, even though we've been working on a large number of disease outbreaks and pathogens over the past decade or so at TGen, we were able to jump in really quickly with COVID and actually kind of retooled all of our resources to be able to make sure that we were getting eyes on this, getting intel on the pathogen as quickly as possible. And that means sequencing the virus. And we could sequence it straight out of those positive samples, those MP swabs, and later on the saliva samples. And by doing that, we get to understand kind of all the secrets that are in the genome. We get to track the viruses as they move around the globe. We get to build these viral family trees, what I kind of call the ancestry.com for COVID. And we can see how the virus is evolving. We get to see the relatedness between individual strains and detect and follow outbreaks as well. And then maybe a little more pedestrian and a little less complex, but no less important, is actually just tracking these variants that we all keep talking about. And I'll get to that, obviously Omicron, the most recent. But really one of the big uses and that we're excited about is to be able to use this for epidemiology purposes. So genomic epidemiology to understand local outbreaks. We work with local health departments and tribal health departments as well to understand different outbreaks that were happening within their communities, so we could see how the outbreak moved, say, through a series of facilities and what was the start of it, and as well as then monitor larger outbreaks and understand what intervention efforts may be working. And then maybe a little bit more fun, we actually were able to use this working with Major League Baseball during the 2020 season and understand the clusters they were seeing and nail down what city they started in, and et cetera. But as I mentioned, tracking the variants has become really one of the more important things, or at least one of the ways that most people have been seeing the use of genomics. And so we have been sequencing and identifying these variants really since the beginning of the pandemic, but it hasn't been until the beginning of 2021 that people started actually talking about variants because they were getting named these Greek letters. And so on the left-hand side, that's April. That's looking at the different proportions of the different variants in Arizona. And we had a plurality of alpha, which was that one that came out of the UK. Y'all can remember that one. It seems ages ago. And you can see below that there's other slices of colors. Those were other variants that we were seeing: epsilon, iota, gamma, et cetera. And then as we go to May, we start to see this little pink strip that's occurring in the middle, and that was the Delta variant. We actually had a couple cases in April. It didn't show up, but then in May, and then we could see by June, the next month, that pink is growing larger. The pink and the purple are Delta. And then it grew to become not only the dominant, but really the only strain we were seeing in November and then into December. So much so that we developed on this tracker, and I should mention that dashboard up there is publicly available to everyone. And I'll give that link out later too. We're looking at the subvariants of Delta, because each one of those now we can look at as a variant, and some of them are important, some are not. They disappear just like the other variants we were tracking. We've used this to actually identify and now investigate a large cluster that was occurring in one of our universities as well. So this is still being actively used. But if we go back to this screen, we can see in December, right at the bottom there, there's this little brown sliver, and this is Omicron, which has shown up and given us now 15 genomes. We're going to see more and more. We're only partway through December. We're already seeing it's almost 1% of what we've sequenced. I imagine that's probably going to get up closer to 5% by the end of this month, and maybe a lot more by next month. And so Omicron, I'm just going to touch on this a little bit of the virology, but we only really know this because we sequence it and look for those mutations. This is looking on the left-hand side, this is looking down on top of the spike protein and looking where all those mutations are occurring in that really important receptor binding domain where it interacts with the human cell, can get in faster, replicate faster. And so we can see in yellow, those are all the mutations that were occurring. And that's quite a bit in to kind of compare to Delta, that figure on the right-hand side. Delta, where you see all the red and some of that blue and green, but all the red, those are all the new mutations that occurred in Delta, which we thought was a lot of new mutations. And then in Omicron, on the right-hand side of that figure, you see so many more mutations occurring. This has really changed the nature of this virus and seems to be giving us a different phenotype that we're seeing with this particular virus. And it's not just in the spike protein or in that receptor binding domain. That's what's in the middle here. That's where a lot of them are, and that's what's most concerning. But we are seeing mutations throughout the genome, and some of these mutations actually also seem to affect the virus. But the ones in the spike are the most important. They do change and seem to enhance the affinity for the ACE2 receptor on the receptor on the human cell, and so that the virus can get in much faster and replicate faster. And we're seeing that occur in the laboratory, and I think we're seeing that occur in the epidemiology of this virus as well. We're also seeing other mutations that do evade some antibodies or allow the virus to evade some antibodies. So we're not seeing as much of effectiveness, and that's really, we're able to pinpoint this and study this very closely by incorporating the genomics. One more look at this. This is the big family tree. Again, this is the global family tree, and that little red group of dots there, that's Omicron. That's coming out there at the end of 2021. That's the timeline across the bottom. And if we zoom in on that, one of the things that's interesting is we look at the branch that leads out to these Omicron instances, and that's a very long branch. It's got 50 mutations on it, as we know, but that branch goes all the way back to one of the earlier main lineages of this virus back in early 2020, which means that this lineage is actually fairly old, but we're only seeing it now. It hasn't been replicated. It's not been, or has been replicating in the population. So this leads us to try to understand, where did this come from? We think that there are 3 mechanisms for having all these mutations occurring. The first, and probably the most likely, is that you had an individual with a long-term infection, typically someone who's immunosuppressed, that can't clear the virus. The virus keeps replicating, and every time it does, it has a chance to pick up another mutation. This has been the documented mechanism in the past. And even especially including the variants that have come out of South Africa. And so it's thought right now that this is the likely mechanism. We don't know patient 0. We actually don't know exactly where the strain started. It's just the outbreaks were first seen in South Africa. Another mechanism would have been animal spillover from humans to animals. We're seeing a lot of that occurring. And in some cases, actually only in one really documented case, we've seen that once that occurs, there are selection factors in that animal species that actually will select for different mutations of the virus that we weren't seeing in the human side. And then it could spill back over into humans. This happened with the mink farms that we were seeing before. That's a possibility, probably less likely. And then maybe the one that's more unlikely, but also possible, is recombination, where you have a person who's infected with more than one strain of coronavirus. And then you get this mixing occurring as the virus replicates. It can mix part of its genome. You get this kind of Frankenstein virus. This is how we get a lot of changes in influenza many times. This seems less likely. Looking at the mutational profile, this is thought to be more unlikely, although there's some proponents for this. So still being investigated. And now my last slide, thinking forward, genomic epidemiology and what I call pathogen intelligence is something that we really need to move forward as we move out of this pandemic and into all of our other issues for both clinical medicine and public health. We do have the technical capabilities now to test and sequence every case, not just of COVID, but of all the other critical pathogens we see every day. We've been working on democratizing the technology, moving towards getting it same-day turnaround and down to the $25 genome, which makes it really as cheap as any other laboratory test that we're running. Democratizing the data, which means that we're automating it, so you don't have to do all this coding and have all these computational biologists working on it. But then also have easy visualizations like the dashboard for people to understand and use the data. We can investigate these mutations and variants, but also importantly, we want to build the future capacity, train local laboratorians and epidemiologists to incorporate this into their shoe leather epidemiology or into their hospital epidemiology to track these outbreaks, identify them much sooner and have more information. And lastly, my shout out, prioritizing bringing advances to the native peoples of the Southwest. We don't need trickle down technology. We can really leapfrog, and we are by actively working with tribal health departments. So I've hit my limit. I feel the hook.
No, look, phenomenal job summarizing a lot of really important pieces of work as well as updates. Again, I invite folks to enter questions into the chat or the Q&A. We will come back and ask questions at the end. Before we move to our next presenter, one brief question, Dave. How long did it take for Delta to become the predominant variant? And should we expect something potentially similar for Omicron?
So it took a matter of about 3 months for it to become the dominant variant around the globe, essentially, and the same for Arizona. You know, we saw a couple cases April, May, it really took a foothold. And then by June, we could tell it was going to be the dominant one and was taking over. By the end of June, it was the dominant one. So I think it's quite feasible. It moves that faster, even faster, given what we're seeing with this particular variant. The good thing we have is a lot of immunity out there working for us that helps to slow it down. So we'll see what happens.
Yeah, very important topic. I'm sure Dr. Orenstein is going to comment on that when we get to him. So thanks very much, Dr. Engelthaler. We'll come back to you with some questions during the Q&A or as they appear during the course of today's session. I'd like to turn the podium over virtually to my friend, Rebecca Sunenshine. Dr. Sunenshine is the medical director for disease control in the Maricopa County Public Health. And Rebecca, thanks for being here. I'll turn it over to you.
Thank you, Mark, and thank you to Narba and everyone for having me today. So I tried to keep this really high level because it's been there's a lot that we've learned in public health over the last 2 years. So I really tried to focus on things that we didn't necessarily know going in. Next slide, please. This is my disclaimer. Next slide, please. So number one thing that we have definitely learned is that masks decrease respiratory disease spread, mortality, and actually support the economy. So there have now been more than 50 studies that have demonstrated that masks and mask requirements or mask policies decrease COVID-19 transmission. And those are in a laboratory level, in individuals in the real world, looking at protection of individuals versus protection of those around the person wearing the mask, and as well as at a population level at a school, city, state, country, and world level. And there's actually 3 studies that show that masking in a countrywide level reduces mortality for the population. And I'll show you one of those. And there was a US economic analysis that showed that increasing universal masking by 15% could prevent the need for lockdowns and reduce losses up to $1 trillion or 5% of the gross domestic product. So having mask requirements around the world during the holidays last year also virtually eliminated flu and RSV transmission. Now, I don't want to say that it's causal, but I think most experts believe that the reason why we hardly saw any flu and respiratory syncytial virus last year is because there were so many mask policies. And I say that because I think coming into this, everyone in public health really focused on physical distancing, keeping people apart, and stopping large gatherings as the main thing that we could do to prevent transmission in a community. But the simple act of wearing cloth face masks or requiring them has as much or more of an impact and doesn't inhibit economic, people going to work, businesses functioning. So that was a big learn for us. Next slide, please. So I just wanted to show you this slide. This is data from 200 countries, and they looked at countries that had a mask requirement within 15 days, a month, and within 2 months. And once they saw the increase in, this was the original COVID strain, those countries that had a mask within 30 days had a far less mortality than those countries that never had a mask requirement or waited until 60 days later. And I think that really shows you on a worldwide level how important masks are. Next slide. I just threw up these because I know this is being recorded in case you wanted to know what those over 50 studies were. Next slide, please. The number 2 thing that we learned in public health and in the community is that kids need to stay in school. So now that we know that masks work really well to prevent respiratory disease spread, including in schools, we recognize that the benefits of keeping kids in school outweigh the risks of COVID transmission. And I believe that will be true. This is an editorial. No matter how contagious the disease is, even with Omicron. So the benefits of keeping kids in school include academic, social, emotional, and physical health of the students, and it also allows parents to go to work. We now have lots of data from lots of different studies and jurisdictions in the United States that show that the risk of secondary transmission in schools ranges somewhere from 0.2% to 4% in the literature. And that depends on the mitigation strategies and the policies that are in place in schools. Granted, we do not have data yet for Omicron transmission. This is mostly with Delta and the prior strains. That being said, that 0.2% comes from LA. That was with Delta, and they do have a mask requirement in place. So the studies that had mask requirements in place in schools show a secondary transmission rate, which is how many people who are exposed to COVID in a school setting actually get the disease. It's less than 1% when masks are required, even with Delta. And that study, I believe, will be published in the next 24 hours. I was lucky enough to see the preliminary data, which is why we're basing some of our policy changes to try to keep kids in school. Next slide, please. I think you all know the risks of prolonged school closings, that it decreases access to services, including food, mental health, and special ed, and it disproportionately affects children with lower socioeconomic status. It does increase mental health issues in children, and it has been shown to be associated with a mean loss of years of final education attainment, and also actual years of life lost. And so I thought that study was really impactful, and it really should motivate us to continue to keep kids in school no matter what happens with this pandemic. Next slide, please. So these are some more supporting references for the recording. Next slide, please. Big lesson learned number 3, pandemics are political. The role of public health is to follow the science, update leadership when new information is learned, and make recommendations based on the science, the data that are available, and what is doable in the community that we're in. And I can't emphasize enough that recommendations must balance political, social, and economic context with the science. We really do need to take all those things into account. It's important to present the science and then sort of what the other pieces are that we all need to take into account to maximize the impact of the science where you are based on the political, social, and economic context. Next slide, please. So number 4, big lesson learned. And part of this, we obviously knew that vaccines are highly effective, and we also knew they were not perfect. But where we are now in public health with vaccines, and there's a lot of debate going back and forth, and Dr. Engelthaler and I have talked about this a lot, vaccines are the best tool we have moving forward. And that's even true for people who have already been infected. We know that adding a vaccine dose to somebody who's been infected with the disease dramatically improves protection against the virus. When viruses mutate as rapidly as COVID-19 does, which Dr. Engelthaler just showed us, herd immunity is really difficult to achieve. And that's why you're not hearing Dr. Fauci or anyone else talk about what level herd immunity is. Herd immunity changes based on the R0, or the ability of the virus to infect people. Once a person is infected, the R0 is how many people that person infects. And that number changes based on what's happening in the environment, as well as with the virus strain. And when it's changing this rapidly, herd immunity is not as reasonable as a goal. So we need to use vaccines and other interventions to try and slow the spread. So we will likely continue to require COVID-19 boosters in the future. And talking to some folks in the vaccine world, the thing that makes the most sense to me is combining the flu and the COVID-19 vaccines. That way people can get protected against both viral respiratory diseases at the same time. We now know that you, from a medical standpoint, you can receive both simultaneously. And I know that at least Moderna is working toward a combined vaccine, and others may be as well. And we also know that countries have to work together to distribute vaccine, or the disease will continue to have those opportunities to mutate more. And so we need to try and equitably distribute vaccine. Next slide, please. All right, so the last lesson learned from the public health perspective is we do need a plan to combat misinformation. The internet and social media seem to be able to spread misinformation faster than we can provide accurate information. We know from data that healthcare providers and public health need to come together. And we have really good data to show us that people listen to their healthcare providers. So you guys are in a really good position to help clear up any misinformation. Next slide, please. And I was just given this slide this morning about the misinformation mouse, and it talks about that Swiss cheese effect of all those layered intervention strategies. None of them are perfect alone. When you layer them over each other, the holes get covered, and then the misinformation mouse comes in and eats away at the cheese. So that's just a reminder to say that we all need to come together and keep providing accurate information and figure out a way to put it out there even more strongly than the misinformation. And with that, I will give it back to Dr. Carroll. Thank you.
Dr. Sunenshine, thanks so much for, again, in such a short period of time, looking back over 2 years and synthesizing down to 5 key lessons learned that I think are super impressive. As a pediatrician, I'm so appreciative of the focus on children in school. But for anyone watching today and anyone watching on a video recording, those reference lists are really important. I've not seen them put together like that. Looking at the data and the science that's available related to not just vaccines, but masking and spread, that's very impressive. So thank you so much for that. So we're going to move, before we go to some questions, we're going to move to Dr. Orenstein. Dr. Robert Orenstein's the chair of infectious diseases at the Mayo Clinic, Arizona. And Jen, if you can bring up Dr. Orenstein's slides, I'll turn the podium virtually over to you, Bob. Thanks much.
Great, thank you. So thanks for inviting me to speak. And I guess my disclosure today is that I think there's only one item I'm going to discuss that actually is FDA approved. Everything else is technically investigational. And I'll try to give you some preliminary information on a lot of these therapeutics. Next slide. So I kind of look at the therapeutics that are coming around for COVID in a bunch of different categories. There are those that enhance our immunity. There are those that prevent infection. There are some things that we might use in early treatment. Where we really started was in treating the hospitalized patients. And another area where there's really not much and we really need a lot more investigation is into long COVID therapeutics. Next slide. So this is a slide that was in Clinical Infectious Diseases last year that kind of looked at where different types of therapeutics might work in COVID-19. And really the message here is that antiviral therapy, at least the current ones that we have, really have to be given quite early in the disease to have any significant impact. The same may be true with antibody therapy. And then once the disease becomes established and there's a host immune response, really the key at that point is trying to control that host immune response so it doesn't overreact and decrease the amount of inflammation so that we don't end up with significant lung disease. Next slide, thanks. So really, if you think about preventing COVID-19, I like to look at it from the perspective of HIV, where we have pre-exposure prophylaxis. There are 2 drugs that are being looked at that are not really at this point yet. We have the Malnupiravir, which we'll talk about in a few minutes, and we have another drug that Pfizer has made called Paxlovid, which we'll talk about. But the one that we all probably have been getting questions about over the last 48 hours is the AstraZeneca monoclonal antibody that's been engineered to last for quite a long time, a minimum of 6 months. And that's called tixagevimab, I spelled that wrong on there, and silgivimab. And this is typically given as an intramuscular injection, 1 into each cheek of each of these agents. And based upon a study I'm going to show you in a few minutes called the Provent study, this was highly effective at reducing infection in patients that were at risk for developing COVID-19. And really where this is going to play a role is in those individuals who either were vaccinated and can't respond to the vaccination, or in those individuals who, for some other reason, cannot get vaccinated. Next slide. So this is the Provent preliminary analysis, which showed that there was about a 77% relative risk reduction in the risk of symptomatic illness in people that were at risk of developing COVID-19. Now, one of the caveats of all of these trials of therapeutics and preventive therapeutics is where they get done and what the rates of infection are. So you'll see across the board when you're studying monoclonal antibodies and antivirals, depending upon the population you studied, the placebo infection rate could be quite low or could be quite high. And as you can see in this study, only 1% of the placebo arm actually developed symptomatic illness. Whereas when you look at some of the other studies from Pfizer and Merck, rates of infection in that group were higher because of probably a little higher risk population. And those rates are in the 5 to 6% range. Next slide. As far as adverse events, one of the things that I was worried about with this is that if you give a monoclonal antibody that potentially could stick around for 6 months or longer, what happens if you get an adverse event? Fortunately, there were not a lot of adverse events in the treatment group. They were comparable to the placebo group. And interestingly, no deaths were reported in this long-term study of this monoclonal antibody. Next slide. Now, the next place is post-exposure prophylaxis. So this would be the case where maybe your housemate or somebody else developed acute infection, you were in close contact, you're at high risk of developing disease. We have the Regeneron COVID that we know has been studied in this situation and seems to be effective at reducing the risk of infection in those individuals. The problem with using these agents in this setting is that we still don't have an adequate supply of these agents. And because they come through a somewhat awkward mechanism to us, it makes it very difficult to try to use these for post-exposure prophylaxis when we know that these are highly effective for people that have early disease. And most of the time we're reserving these for those with early disease. So that brings us to the antiviral therapies, which we still don't yet have. Malnupiravir was reviewed by the FDA, and the panel did agree to move it forward. Paxlovid, which is the Pfizer protease inhibitor, this drug is slowly moving forward, but has not yet been reviewed by the FDA. And what you've mostly seen have been press releases from the manufacturer. Next slide. So this is the guidance for post-exposure prophylaxis for the Regeneron monoclonal antibody. And again, I just want to highlight that this is really for those that are high risk for progression to severe disease. So it's not simply that you're exposed, but you're at high risk for progression. And often we'll get calls from people who are fully vaccinated and then get exposed to someone who are looking to get this. And typically we have to tell them that they're not in the high risk category and that they need to wait and see if they develop symptomatic disease, and then they might be eligible at that point. Next slide. Next, yeah. So let's talk about early treatment. Early treatment for COVID-19, there are several things that have been established and work quite well. And these are typically the monoclonal antibodies, the Regeneron, the Lilly, and the GlaxoSmithKline antibodies all have been very effective at early treatment. Most of them show about a 70 to 80% reduction in hospitalization and or death. There's our old friend convalescent plasma, which we used a lot of early in the pandemic, which has now really been shown to not be particularly effective in most of the people that we've given it to. There was recently a large meta-analysis that essentially concluded that convalescent plasma, even when given early, may not be effective. But I can tell you that at Mayo, we were in a trial with Hopkins looking at using this similar to monoclonal antibodies in the outpatient setting. And the data from that is currently being reviewed, and it looks like it may be somewhat positive. What about antiviral therapy? Well, really, we don't have these yet. We do have ivermectin, we do have fluvoxamine, and those have been used by a number of our patients based upon what little data has been published, neither of which have been particularly effective and neither established as being effective in any sort of randomized controlled manner. There's an oral antiviral drug called Camostat. We've been studying that on the inpatient side here at Mayo for about a year now. This is an agent that blocks TMPRSS2, which is involved in the co-receptor for entry of the virus into the cell. There was a lot of hope for these compounds early on, but from the data that we've seen, it doesn't look like it has a great effect. Remdesivir, our old friend remdesivir, which most of us are using on the inpatient side. I'll show you some data in places that have well-established outpatient infusion centers where remdesivir can be very effective at reducing hospitalization if given as an outpatient. Next slide. So this is a study that was recently presented, phase 3 trial of remdesivir in non-hospitalized high-risk patients with COVID-19. So you should think of this as the people you might give a monoclonal antibody to. They were given just 3 days of remdesivir, and they looked at the all-cause mortality and risk of hospitalization between the placebo and the remdesivir group. Next slide. And you can see that in this group that received outpatient IV remdesivir, there was a reduced number of hospitalizations and a reduced number of deaths in the remdesivir arm, 0.7 versus 5.3%, which was statistically significant. And also the rate of medically attended visits was also lower in the remdesivir group. So it's a proof of principle that if you can give remdesivir as an outpatient, that this antiviral drug given early may be effective at reducing hospitalizations and death. Next slide. Talking about the monoclonal antibodies, we've been using a lot of monoclonal antibodies here at Mayo over the course of the pandemic. This is just a slide illustrating the volumes, and you can kind of see that our volumes have been going up over the last several weeks, infusing about 100 to 120 people a week in the last several weeks with monoclonal antibodies for treatment of early COVID-19. Again, a very effective therapy, but you really need the infrastructure to be able to do this. And of course, you need accessibility to the monoclonal antibodies, which unfortunately may not be quite as accessible as we would hope. Next slide. Just to highlight where there are centers around the county, because often people will call and ask, where they can get monoclonal antibodies. There is a map that you can go to on the Arizona Department of Health Services website that will direct you to places where monoclonal antibodies are available throughout the state. Next slide. So let's talk a tiny bit about virology, just as a opportunity for where antiviral drugs might work. So to start with, we give antibodies to really block the attachment of the spike protein to the ACE receptor. The second target that we talked about is that one you can see at the top called TMPRSS2, which is also involved in entry into the cell. Unfortunately, if the virus then gets into the cell, it uses our host machinery to replicate. And one of the places that you can block that is by blocking the transcription of the viral RNA. And that's essentially what your drugs like remdesivir and Malnupiravir do. The newest kid on the block is the protease inhibitor from Pfizer, and this is blocking the viral protease, which doesn't allow the virus to break up its pieces into pieces to reassemble new virus. And these in HIV have been incredibly effective at preventing spread of HIV and reducing HIV viral load. And the current protease inhibitor, the Paxlovid, which Pfizer has, reduces the viral load by about 1 log. Next slide. Next slide. So this is just showing you the structure of the nucleoside analogs. We have a lot of familiarity with these from using nucleoside analogs for treating HIV and hepatitis C. As I mentioned, the one that has come furthest along is the Malnupiravir oral drug. This is a little bit different than remdesivir. So rather than causing chain termination, what happens with the Malnupiravir is it inserts into the growing viral RNA and actually causes mutagenesis and basically makes so many mistakes in the construction of the new chain that the virus falls apart. The problem with this is that some of these nucleotides could potentially get integrated into the host DNA, and therefore there's a caveat about using these drugs in women who might become pregnant or their partners who might impregnate them because of potential concerns for mutagenesis. Next slide. So this is Malnupiravir. This drug was approved in the UK and in Europe. I just looked today to see whether there's been any distribution, and I could not find, that they had a distribution plan for the drug yet. The name Malnupiravir, as you probably know, comes from Malnavir, which is the Thor's hammer. Great name, except that it doesn't really hammer the virus quite as well as we'd like it to. The original press release from Merck suggested about a 50% reduction in risk, but it turns out that the final data is about a 30% relative reduction in risk, which is not that great. This drug is taken quickly. Both this drug and the Pfizer drug work well when given very early in the disease course, which will pose an issue for us in how we're going to deliver this to the patient, because it's optimal at 3 days, a little less optimal at 5 days, and once you're beyond a week of symptoms may not be very effective at all. Next slide. This is the new Pfizer drug. This is the packaging coming from Germany, I believe. Paxlovid is the brand name. The generic name of this will be difficult to pronounce, Nirmatrelvir. And this is given with a little dose of an old HIV drug called ritonavir. And I bring that up because that's really important, because ritonavir is a very potent inhibitor of cytochrome P450-3A4, which is the major route of drug metabolism for most of the drugs we use. So some of these high-risk patients may be on medicines that are going to interact with the ritonavir, and we have to be aware of that because it may alter their drug levels and cause toxicities. For those of you that have treated patients with HIV, you also know that ritonavir is not the best orally tolerated drug, tends to cause a lot of nausea and some diarrhea. However, in the study, because of the very short course of treatment, it seemed to be relatively well tolerated, and treatment associated adverse events were really similar between the drug and the placebo. And the US government has bought 10 million treatment courses of this. It's not yet been reviewed by FDA, though it looks like it may be a little more effective than the Merck drug for preventing hospitalization and death. Next slide. There are a few adjunctive therapies that people have been looking at in early disease. A lot of these are currently being studied. There's budesonide. There's another inhaled MDI, which was not very effective, that failed. There's some data suggesting SSRIs might be of some value. And there are several companies that are looking at some of these novel probiotics to try to enhance host immunity. Next slide. In hospitalized patients, really, I just want to cover one particular therapy, and that is a drug that we studied here called Lenzillumab. Lenzillumab is a GCSF inhibitor, GM-CSF inhibitor, and it seems to work quite well in early disease. So in people that require oxygen but low flow and haven't moved on to the point of requiring high flow oxygen and ventilation, this drug seems to reduce the risk of going on to mechanical ventilation. Next slide. So this is the trial that we participated in called Live Air. And this study enrolled 520 subjects. We gave the patients IV Lenzillumab every 8 hours for 3 doses, and that was it. And then we looked at the outcomes compared to placebo. Next slide. And you can see in this Kaplan-Meier curve that the Lenzillumab was more effective than the placebo in survival without ventilation, so that more of the patients that got this early seemed to not end up requiring mechanical ventilation. And in an ad hoc analysis, a post hoc analysis, it turns out that if the CRP level was under 150 and you were less than 85 years old, you seem to get the greatest benefit of Lenzillumab. And this is being studied in one of the NIH trials stratified by those markers. Next slide. And this just shows you the adverse events. The Lenzillumab appeared to be very safe and without a significant difference in adverse events compared to placebo. Next slide. Lastly, I just want to mention long COVID. There's not too much going on in long COVID, and this is really an area where we really need therapeutic intervention. The only trial that I could find that looked like it was a relatively large placebo-controlled trial is the trial of AXA 1125. And this is a drug that's been used for hepatic steatosis. It's a 6 amino acid combination, which seems to improve mitochondrial activity. And so it's being looked at to see whether it improves fatigue and some of the other systemic symptoms in long COVID, as well as a variety of other drugs, including some monoclonal antibodies and some other novel SSRIs all being looked at. So that's a rundown of some of the newer therapeutics. Lots of opportunities for us to better understand these, learn their roles, and figure out how to best use them. Thank you.
Dr. Orenstein, thank you. What an excellent summary of a complex and emerging space. And so impressive to hear some of those updates. If you have questions, please put them in the Q&A and chat. Bob, there was a question that came in you might take a look at while Dr. Frey is presenting. And for folks that are joining us, we may nudge a little bit over the top of the hour if you're okay hanging with us. A lot of great information today. I want to give Dr. Frey an opportunity to complete our panel presentation discussion today. Dr. Keith Frey is the Chief Medical Officer for Dignity Health Arizona in the Common Spirit Southwest Division. He's going to speak to us today about well-being for health professionals. Dr. Frey.
Yeah, thank you, Dr. Carroll, and thank you to the NARB Institute for facilitating and enabling today's discussion. You can see my slides, Mark, I trust. Yeah, and I've dropped a few just so that we can kind of keep the pace up. I think this, my title slide probably would be better retitled as the struggle for well-being for health professionals as we're finishing our second year in the current situation with COVID-19. And, I'm going to probably affirm to most of you what you already know with a couple of slides, talk a little about a couple of the frames that we're using inside of our organization to try and help our colleagues support them during this journey, and then help them have sort of a pathway toward their recovery. Like any speaker, I am supported by a great team. I want to particularly thank my two primary colleagues who are working in the well-being space here at Dignity Health, Dr. Gia DeMichael and Dr. Heather Rabin, who are really doing a lot of the heavy working here. Again, I had a couple of slides that showed some statistics, but be that as it may, I think we should all recognize that we have a very beat up and I'll show you in many ways broken healthcare workforce right now. People are tired, exhausted, heroes and heroines on the front lines, particularly emergency room physicians, emergency room nurses, critical care, nurses and physicians, respiratory therapy, pharmacy, people working long hours, extraordinary efforts. And, if I bring the data really into stories and qualitative themes, it's really this state of psychologically feeling broken, which, because of this enormous amount of stress and the prolongation of what we've been going through the last 2 years, this creates a new level of psychological trauma that, perhaps we've only seen in wartime. And obviously the exposure to death a lot of times, the threat to death themselves or to exposing it, this would be primarily maybe for the vaccination piece, but still this concern our colleagues have. Challenges of not having enough protective equipment, that was a big issue 18 months ago, less of an issue now. But as Dr. Orenstein just said, this ongoing awareness of what are the best therapeutics relates to the, at times, helplessness and hopelessness that our healthcare workers have taking care of patients, often because of the shortage of particularly nurses and other key critical colleagues. They're been asked to and stepped into areas that are outside their general scope. That contributes to their stress and some of this trauma. And it makes difficult decisions about rationing care or prioritizing care. And as hopefully most of you know, here in Arizona, we're really teetering on the brink of having to move into that next phase, regrettably, of crisis standards, and all of that brings with it, with beginning to have to ethically go through the drill of who we can provide care for. And of course, then for those of us who come into these noble professions of nursing or as a physician or other healthcare professional, we come into this to save lives. And so there's that sense that of regret about who they weren't able to save, or what could they have done? So, what we see then, the emotional response in collection that we hear as our teams are walking with and both one-on-one and in small group debriefs, emotions, and these are of course not mutually exclusive, they're overlapping: guilt, anger, exhaustion, sense of fear, sadness, hopelessness, frustration, all leading to uncertainty. And so the brokenness can be at the individual level. It can be in a collection of colleagues that are on a unit or in an emergency room or in an operating room or in a clinic. And as this prolongation and this sense of trauma and brokenness continues, we really have a lot of shattering that's going on. So it's really a struggling workforce that we and you are dealing with every day. And we want to acknowledge that. I think we know that, but we really have to move forward. One of the model that we're using at Common Spirit Health, which is our parent company of Dignity Health here in the West, is an adaptation of the Stanford model that really sort of looks at this from a multidimensional lens. It's an interprofessional model, but one that recognizes that both we need to support our colleagues and help give them tools for their own personal sustainability. We need to continue to try and optimize whatever site of care they have on trying to remove some of the irritants, the so-called pebbles in their shoe. And then we need, particularly at the leadership level, to continue to build a culture that is inclusive, is engaging, and supports well-being of our organizations. So, we've got this proverbial fork in the road where traditionally folks coming back from wartime, and I think our colleagues coming through this prolonged pandemic really face a post-traumatic stress direction of anxiety, detachment, sleep troubling, flashbacks, depression, suicidality. And yet we hope that we can continue to work with people to maybe give them an opportunity to move more toward post-traumatic growth, developing a new outlook, appreciation for what they've been through, the personal strength that they've been able to muster, and give them perhaps a new frame and a new outlook moving forward. And part of this is the deepening of relationships they've had with their colleagues through this shared experience. Sort of creates that band of brothers and sisters that they can carry forward in the future. The ability to see themselves maybe beyond what they thought they could do, beyond their potential for new possibilities. That sort of sense of greater strength, personal strength, when they're in a position emotionally to be able to begin to appropriate that, maybe a greater appreciation of life, particularly in the midst of seeing so much tragic loss of life. And whatever their sense of spirituality, we're certainly hearing increasing stories of people really sort of returning to their core belief system through an experience like this. So, we hear things like, I love what I do, I've made a difference, and we want to listen to that and be able to allow presence as people tell their story. We hear stories of what we have been through together as a group, as a unit. The recognition, again, of new skills, strengths, and abilities. We hear, if you will, I didn't know I had this in me. And again, trying to be, particularly in leadership roles like I am in and many of you, are really trying to be purposeful in our communication, in building trust, relationships, really coming alongside, providing in our usual meetings some space for people to process and perhaps share some of their stories. So Mark, I know we're a little short on time, so I'm just going to finish with a couple of slides here. I love this metaphor that our team is using of unbroken. Poetically translated to golden joinery, kintsugi is that centuries-old Japanese art of fixing broken pottery. Rather than hiding the cracks, the technique involves rejoining the broken pieces with a lacquered mix of either gold, silver, or platinum. The point, of course, being that as we put ourselves and our colleagues back together, the whole piece of pottery looks as beautiful as ever, even while we can own the broken history that we're going through right now. So we'll leave you with this Ernest Hemingway quote that we're stronger in the places that we've been broken. And I want to again thank the leadership of the NARBA Institute and our key colleagues around the state. We're about a year out from having formed a statewide well-being collaborative. It's really an open architecture model where all the health system, major health systems, access, the state, many of the payers, professional societies are contributing together some of the things that are working across various organizations on how we can journey with our healthcare professionals. So Mark, I'll turn it back to you.
Dr. Frey, thanks so much for that very nice summary of such an important topic. The health professionals include our public health colleagues all the way across our systems, from first responders to our ICUs. And the journey over the past almost 2 years now has obviously been a really challenging one for all of them and for all of us and for all of you joining us today. we've had a nice opportunity to hear from 4 leaders and experts in our state and in the country. And I hope that reaffirms for all of us the tremendous power and capability, and I invite the presenters to please come back on camera if you're still there, but the tremendous power and the capability for us to, as Dr. Frey so nicely concluded, to keep and bring pieces together, pieces maybe that are newly forming new shapes, but pieces that are also need to be put back together. And committing to that as a community moving forward, I think will be so important as we continue to advance through challenges of uncertainty, whether it be Omicron or any other variant of the Greek alphabet or the next version of nomenclature can throw at us. I am convinced that working together with such leaders as we've heard from today, with all of you that have joined us, and with the entire community across Arizona, that we can respectfully continue to listen, learn, improve, and provide the best level of support for the well-being of our entire community, whether it's those who need help and those who are ill, or those who are taking care of folks who are in challenging situations or ill. That's unfortunately all the time that we have today. There were some great questions. Thanks for folks, Dr. Engelthaler and Dr. Orenstein, for responding to them. We'll look forward to continuing conversations like these and creating opportunities for experts such as those today to share with you and with all of us what we've learned along the way, and to advance key themes that we know are important to all of us and we've heard from our presenters today. As we close the year on COVID, we know that we're not closing our experience with COVID. So together, let's please commit moving in 2022 to taking a breath together, to helping each other out, to supporting what we need to do moving forward, and to celebrate the strengths that we have, such as the great individuals who are presented on behalf of their teams today, and for all of you. So on behalf of the NARBA Institute, Blue Cross Blue Shield of Arizona, I wish you a very happy, healthy, and peaceful holidays, and look forward to continuing to work with you and hear from you in the new year. Happy New Year, everyone.
Thank you, Mark.